Welcome to this presentation on the pharmacology of central nervous system infections. Today, we will explore the critical and life-threatening conditions of brain abscesses, subdural empyemas, and spinal epidural abscesses. Managing these infections requires a nuanced understanding of both microbiology and pharmacology, specifically how drugs behave within the unique environment of the central nervous system. We will focus our discussion on four major antimicrobial classes: cephalosporins, carbapenems, specifically meropenem, metronidazole, and vancomycin. By the end of this session, you will understand how to apply the principles of pharmacokinetics and pharmacodynamics to optimize therapeutic outcomes for these complex neuroinfectious diseases. In this lesson, we will explore the fascinating world of focal infections of the central nervous system, or CNS. Understanding how these infections develop is the first step toward effective diagnosis and treatment. We begin with the pathophysiology of focal CNS infections. Learn how bacteria, fungi, parasites, and other pathogens invade the brain and surrounding tissues. Discover how the body's immune response can help fight infection, but may also contribute to tissue damage and neurological complications. Next, we examine the key antimicrobial agents used to treat these infections. Understanding how these drugs work is essential for making informed treatment decisions. We will look at their mechanisms of action and see how they target specific microorganisms while limiting further disease progression. Choosing the right drug is not just about killing pathogens. It also depends on how the drug behaves inside the body. This is where pharmacokinetics and pharmacodynamics become important. Explore how absorption, distribution, metabolism, and elimination influence treatment success. Learn why drug concentration, dosing schedules, and penetration into the CNS matter so much in clinical practice. We will also discuss the major clinical applications of these medications. Understand when specific drugs are preferred and how treatment strategies differ between infections. At the same time, recognize common adverse effects that may affect patient safety and treatment adherence. Learn how drug interactions can alter effectiveness or increase the risk of toxicity. Finally, we bring everything together through clinical case studies. Real-world scenarios help connect theory with practice. Analyze patient presentations, interpret clinical findings, and develop evidence-based treatment plans. See how physicians, pharmacists, nurses, microbiologists, and other healthcare professionals work together to achieve the best possible outcomes. By the end of this lesson, you will have a stronger understanding of focal CNS infections, the drugs used to treat them, and the clinical reasoning required to manage these challenging conditions effectively. Welcome to our introduction to focal infections of the central nervous system, commonly known as CNS infections. These conditions are among the most serious neurological emergencies encountered in clinical practice. Without rapid diagnosis and treatment, they can lead to permanent neurological damage, disability, or even death. Focal CNS infections occur when microorganisms invade a specific area within or around the brain and spinal cord. As the infection progresses, inflammation, swelling, and the accumulation of pus can place dangerous pressure on delicate nervous tissue. This can quickly compromise normal brain and spinal cord function. One important example is a brain abscess. This is a localized collection of pus within the brain tissue itself. Patients may develop headaches, fever, seizures, altered mental status, or focal neurological deficits. Early recognition is critical because delayed treatment can have devastating consequences. Another serious condition is subdural empyema. In this infection, Pus accumulates between the dura mater and the surface of the brain. The infection can spread rapidly and often presents with severe headache, fever, confusion, or neurological deterioration. It requires urgent medical attention and, in many cases, surgical intervention. Spinal epidural abscess is another life-threatening focal CNS infection. Here, infectious material collects in the epidural space surrounding the spinal cord. Patients may initially experience back pain and fever, but untreated infection can progress to weakness, paralysis, or permanent neurological injury. Managing these infections requires much more than simply prescribing antibiotics. Successful treatment depends on a multidisciplinary approach that combines medical expertise from several healthcare specialties. Each team member plays a vital role in improving patient outcomes and reducing complications. Neurosurgeons are often responsible for draining abscesses, relieving pressure, and obtaining samples for laboratory analysis. Infectious disease specialists guide antimicrobial selection and ensure that treatment effectively targets the causative organism. Clinical pharmacists contribute by optimizing drug dosing, monitoring for adverse effects, and helping prevent harmful drug interactions. When these specialists work together, patients benefit from faster diagnosis, more effective treatment plans, and better long-term recovery. This collaborative approach remains one of the most important factors in successfully managing focal CNS infections. Throughout this lesson, we will explore these conditions in greater detail and examine the principles that guide their diagnosis, treatment, and multidisciplinary care. To understand brain abscesses, we first need to explore how they develop. Brain abscess formation is a dynamic process that occurs in several stages. Each stage brings important changes to the brain tissue and influences treatment decisions. The first stage is known as early cerebritis. This is the initial response to infection within the brain. Microorganisms invade the tissue and trigger inflammation. Blood vessels become more permeable, allowing immune cells to enter the affected area. As a result, swelling, or edema, begins to develop around the infection site. At this stage, the infection is still poorly defined. There is no clear boundary separating infected tissue from healthy brain tissue. Patients may experience symptoms such as headache, fever, or subtle neurological changes as inflammation progresses. The second stage is called late cerebritis. During this phase, the infection becomes more aggressive. The center of the infected area begins to undergo necrosis, meaning the tissue starts to die. Large numbers of inflammatory cells accumulate in an attempt to control the infection. As necrosis expands, pus starts to form within the affected region. The surrounding brain tissue remains inflamed and swollen. This increasing mass effect can raise intracranial pressure and worsen neurological symptoms. The third stage is capsule formation. The body attempts to contain the infection by building a protective wall around it. Fibroblasts and connective tissue form a fibrous capsule that surrounds the collection of pus. This creates the characteristic structure of a mature brain abscess. At first glance, capsule formation may seem entirely beneficial. The capsule helps prevent the infection from spreading into surrounding brain tissue. By isolating the abscess, the body limits further damage and reduces the risk of widespread infection. However, this protective barrier also creates a therapeutic challenge. The fibrous capsule can act as an obstacle to antibiotic delivery. Some antimicrobial agents may have difficulty reaching adequate concentrations within the abscess cavity. As a result, treatment can become more complex and prolonged. This clinical implication is extremely important. Effective management depends on selecting antibiotics that can penetrate the central nervous system and reach the site of infection. In some cases, surgical drainage may be necessary to remove pus and reduce pressure within the brain. Understanding these stages helps clinicians recognize disease progression and choose the most appropriate treatment strategy. It also explains why early diagnosis and timely intervention are critical for achieving the best possible outcomes in patients with brain abscesses. Now let's explore another dangerous focal CNS infection known as subdural empyema. This condition is considered a neurological emergency because it can progress very rapidly and cause severe brain injury if not treated promptly. Subdural empyema occurs when pus accumulates in the subdural space. This space lies between two protective layers that surround the brain, the dura mater on the outside and the arachnoid mater beneath it. When bacteria invade this region, an intense inflammatory response develops, leading to the formation of a collection of infected material. What makes subdural empyema particularly dangerous is its unique anatomy. Unlike some other compartments within the body, the subdural space contains very few natural barriers. It lacks septa, or partitions, that could otherwise limit the movement of infectious material. Because there are no effective internal barriers, the infection can spread quickly across large areas of the brain surface. Instead of remaining confined to a single location, pus can travel freely within the subdural space. This allows inflammation to involve extensive regions of the cerebral hemispheres in a relatively short period of time. As the infection spreads, pressure on the underlying brain tissue increases. The inflammatory process can impair normal brain function and disrupt blood flow. Patients may develop severe headaches, high fever, vomiting, confusion, altered consciousness, seizures, or rapidly worsening neurological deficits. The speed of disease progression is one of the defining features of subdural empyema. A patient who initially appears stable can deteriorate significantly within hours or days. For this reason, early recognition and immediate intervention are critical. Treatment must begin as soon as the diagnosis is suspected. Clinicians typically initiate aggressive empirical antimicrobial therapy before the exact causative organism is identified. Broad-spectrum antibiotics are selected to cover the most likely pathogens while laboratory investigations are underway. However, antibiotics alone are often not enough. Because large collections of pus can compress the brain and serve as a persistent source of infection, surgical intervention is frequently required. Neurosurgeons may perform procedures to drain the empyema, reduce intracranial pressure, and obtain specimens for microbiological analysis. Successful management depends on close collaboration among neurosurgeons, infectious disease specialists, clinical pharmacists, radiologists, and critical care teams. Rapid diagnosis, prompt antimicrobial therapy, and timely surgery can dramatically improve patient outcomes. Understanding the pathophysiology of subdural empyema helps explain why this condition demands urgent and aggressive treatment. Its ability to spread rapidly across the brain surface makes it one of the most serious focal infections of the central nervous system. Let's now turn our attention to spinal epidural abscess, another serious focal infection of the central nervous system. Although it occurs outside the spinal cord itself, it can rapidly threaten neurological function and become a medical emergency. A spinal epidural abscess develops when pus accumulates within the epidural space of the spinal canal. This space lies between the outer covering of the spinal cord and the surrounding vertebral structures. Infection may reach this area through the bloodstream, from nearby tissues, or following spinal procedures and trauma. As bacteria multiply, inflammatory cells and infectious material begin to collect within the confined epidural space. Over time, this growing abscess occupies valuable space inside the spinal canal and creates increasing pressure on nearby structures. The primary mechanism of injury is direct mechanical compression. As the abscess enlarges, it presses against the spinal cord and spinal nerve roots. Because the spinal canal has limited room to accommodate swelling, even a relatively small collection of pus can cause significant neurological problems. A second mechanism of injury involves vascular compromise. The pressure created by the abscess can compress blood vessels that supply the spinal cord. Reduced blood flow limits oxygen and nutrient delivery to nervous tissue. If this process continues, spinal cord ischemia and permanent neurological damage may occur. One of the earliest warning signs is severe localized back pain. Patients often describe persistent pain that is intense and different from typical musculoskeletal discomfort. The pain may worsen over time and become increasingly difficult to ignore. As compression progresses, motor weakness may develop. Patients may notice difficulty walking, climbing stairs, or performing routine movements. Weakness can affect one limb, both limbs, or larger regions of the body depending on the location of the abscess. Sensory loss may also occur. Individuals can experience numbness, tingling, reduced sensation, or abnormal feelings below the level of spinal cord involvement. These symptoms often indicate advancing neurological compromise. In more advanced stages, bowel and bladder dysfunction can appear. Patients may lose normal control of urination or bowel movements. This is a particularly concerning sign because it often suggests significant spinal cord compression. The progression from back pain to neurological deficits can occur over hours, days, or weeks. Early diagnosis is therefore critical. Prompt imaging, appropriate antimicrobial therapy, and surgical decompression when necessary can prevent irreversible injury. Understanding the pathophysiology of spinal epidural abscess highlights the importance of rapid intervention. The longer the spinal cord remains compressed, the greater the risk of permanent neurological disability. Early recognition and treatment can make the difference between full recovery and lifelong impairment. When evaluating a patient with a suspected CNS abscess, clinicians often refer to what is known as the classic diagnostic triad. This triad includes three important clinical features: fever, headache, and focal neurological deficits. At first glance, this combination may seem straightforward. If all three symptoms are present, the diagnosis might appear obvious. However, the reality is often much more complex. Let's start with fever. Fever reflects the body's immune response to infection. It is one of the most common signs that an infectious process may be occurring somewhere in the body. In patients with CNS abscesses, fever may be mild, intermittent, or occasionally absent altogether. The second component is headache. This is often the most frequent presenting symptom. As inflammation, swelling, and pressure increase within the skull, patients may experience persistent or progressively worsening headaches. These headaches may not respond well to routine pain medications and can become increasingly severe over time. The third component is focal neurological deficits. These occur when the infection affects specific regions of the brain responsible for particular functions. Depending on the location of the abscess, patients may develop weakness, speech difficulties, visual disturbances, sensory changes, balance problems, or seizures. Together, fever, headache, and focal neurological deficits form the classic diagnostic triad associated with CNS abscesses. For many years, This triad has been taught as a useful clinical framework for recognizing these infections. However, there is an important limitation. The complete triad is present in only a minority of patients. Many individuals will present with only one or two of these features. Some may initially have vague symptoms that resemble less serious conditions. This creates a significant diagnostic challenge. Relying solely on the presence of the full triad may delay diagnosis and treatment. Since CNS abscesses can progress rapidly, missed or delayed recognition can result in serious neurological complications. For this reason, clinicians must maintain a high index of suspicion. Careful attention should be paid to the overall clinical picture, especially when symptoms are progressive or unexplained. A worsening headache, new neurological symptoms, persistent fever, or declining mental status should always prompt further investigation. Modern diagnosis depends not only on clinical findings but also on timely imaging studies and laboratory evaluation. Early recognition allows treatment to begin before irreversible neurological injury occurs. The key takeaway is simple. The classic triad remains an important diagnostic clue, but its absence does not rule out a CNS abscess. Vigilance, clinical judgment, and prompt evaluation are essential for identifying these potentially life-threatening infections. Accurate diagnosis is critical when a focal CNS infection is suspected. Because symptoms can overlap with many other neurological conditions, imaging plays a central role in confirming the diagnosis and guiding treatment decisions. The gold standard imaging technique for suspected brain abscesses is magnetic resonance imaging, or MRI. MRI provides highly detailed images of brain structures and is far more sensitive than many other imaging methods when evaluating infections within the central nervous system. One particularly valuable MRI technique is diffusion-weighted imaging, commonly known as DWI. This specialized sequence helps clinicians assess the movement of water molecules within tissues. Although this may sound highly technical, it provides extremely useful diagnostic information. In a brain abscess, the thick pus within the lesion restricts the movement of water molecules. As a result, the abscess appears as an area of restricted diffusion on diffusion-weighted imaging images. This characteristic finding often helps clinicians identify an abscess with greater confidence. This distinction is especially important because brain abscesses can sometimes resemble other space-occupying lesions on conventional imaging studies. One common diagnostic challenge is differentiating an abscess from a necrotic brain tumor. Both conditions may appear as ring-enhancing lesions after contrast administration. However, their internal contents behave differently on diffusion-weighted imaging. While abscesses typically demonstrate restricted diffusion, many necrotic tumors do not. This makes diffusion-weighted imaging a powerful tool for improving diagnostic accuracy and supporting timely treatment decisions. While imaging is essential, clinicians must also recognize important contraindications during the diagnostic process. One of the most significant concerns involves lumbar puncture, often referred to as an LP or spinal tap. In many infectious diseases of the central nervous system, lumbar puncture is used to collect cerebrospinal fluid for analysis. However, in patients with a suspected brain abscess or other mass lesion causing increased intracranial pressure, this procedure can be extremely dangerous. The reason relates to pressure dynamics within the skull. A brain abscess often creates swelling, inflammation, and mass effect. These changes can significantly increase intracranial pressure, also known as ICP. Performing a lumbar puncture in this setting may suddenly alter pressure gradients between different compartments of the central nervous system. This can trigger brain herniation, a life-threatening emergency in which brain tissue shifts from its normal position. Brain herniation can rapidly lead to severe neurological deterioration, respiratory failure, and death if not immediately recognized and managed. For this reason, neuroimaging is typically performed before considering lumbar puncture in patients with signs of increased intracranial pressure or focal neurological deficits. Understanding both the value of advanced imaging and the risks of inappropriate procedures is essential for the safe management of CNS abscesses. The key message is clear. MRI with diffusion-weighted imaging helps establish the diagnosis, while avoiding lumbar puncture in high-risk patients helps prevent catastrophic complications. When treating serious CNS infections, time is one of the most important factors. Clinicians often cannot wait for laboratory cultures to identify the exact organism before starting treatment. Delays can allow the infection to spread and increase the risk of permanent neurological damage. This is where empirical therapy becomes essential. Empirical therapy refers to the immediate use of broad-spectrum antimicrobial agents based on the most likely causative organisms. Treatment begins before culture and sensitivity results become available. The goal is simple: start effective therapy as quickly as possible while laboratory investigations are still in progress. Once the responsible pathogen is identified, treatment can then be adjusted and targeted more precisely. Because focal CNS infections can be caused by a wide variety of microorganisms, empirical regimens must provide broad coverage. Clinicians need to consider the most common pathogens associated with brain abscesses, subdural empyema, and spinal epidural abscesses. A major target group includes gram-positive bacteria. These organisms are among the most frequent causes of CNS infections and must be covered early in treatment. Failure to address them can result in rapid disease progression. Gram-negative bacteria must also be considered. Certain patient populations and infection sources increase the likelihood of gram-negative involvement. Effective empirical therapy therefore needs to account for these potentially aggressive pathogens. Anaerobic bacteria are another important concern. These organisms commonly originate from infections involving the oral cavity, sinuses, ears, or other nearby structures. Because anaerobes thrive in low oxygen environments, they are frequently implicated in abscess formation. However, selecting an antimicrobial agent is not simply about identifying likely pathogens. Another critical factor is whether the drug can actually reach the site of infection within the central nervous system. This concept is known as CNS penetration. A highly effective antibiotic is of little value if it cannot achieve therapeutic concentrations within infected brain tissue or cerebrospinal fluid. Drug penetration therefore becomes a key determinant of treatment success. One of the greatest barriers to drug delivery is the blood-brain barrier, often called the BBB. This specialized protective system regulates the movement of substances from the bloodstream into the central nervous system. While it helps protect the brain from harmful agents, it can also limit the entry of many medications. Fortunately, infection and inflammation can alter this barrier. During meningeal inflammation, the blood-brain barrier becomes more permeable. This increased permeability allows certain antimicrobial agents to penetrate the CNS more effectively and reach therapeutic levels at the site of infection. Understanding both microbial coverage and CNS penetration is essential for effective treatment. The ideal empirical regimen not only targets the most likely pathogens, but also reaches the infected tissues in sufficient concentrations to eliminate the infection. In CNS infections, choosing the right drug means considering both what you are treating and whether the medication can successfully reach its target. When managing focal CNS infections, medications alone are not always enough. In many cases, surgical intervention plays a crucial role in achieving successful outcomes. The best results often come from combining surgery with targeted antimicrobial therapy. Let's begin with brain abscesses. As an abscess grows, it can increase pressure within the skull and damage surrounding brain tissue. Even when effective antibiotics are administered, the collection of pus may remain difficult to eliminate completely. One of the most commonly used procedures is stereotactic aspiration. This is a minimally invasive surgical technique that uses advanced imaging guidance to accurately locate the abscess within the brain. A small needle or catheter is then inserted to remove pus from the infected cavity. Stereotactic aspiration serves two important purposes. First, it helps decompress the abscess by reducing its size and relieving pressure on nearby brain structures. This can rapidly improve symptoms and reduce the risk of further neurological injury. Second, the procedure provides a sample of infected material for laboratory analysis. Microbiologists can identify the causative organism and determine which antimicrobial agents are most effective. This information allows clinicians to transition from broad empirical therapy to more precise, targeted treatment. Now let's consider spinal epidural abscesses. These infections can compress the spinal cord and threaten permanent neurological function. Because spinal cord tissue is highly sensitive to pressure, prompt intervention is often essential. In many cases, patients require an urgent laminectomy. During this procedure, a portion of the vertebral bone known as the lamina is removed. This creates additional space within the spinal canal and allows surgeons to access and drain the abscess. The primary goal of laminectomy is to relieve spinal cord compression. By reducing pressure on the cord and surrounding nerves, the procedure helps prevent further neurological deterioration and improves the chances of functional recovery. Like stereotactic aspiration, laminectomy also provides valuable specimens for microbiological testing. Obtaining cultures directly from the infected site increases the likelihood of identifying the responsible pathogen and selecting the most appropriate antimicrobial regimen. An important principle to remember is that surgery and pharmacology are not competing treatment options. They work together as complementary strategies. Surgery addresses the physical burden of infection by removing pus and relieving pressure, while antimicrobial therapy eliminates the microorganisms responsible for the disease. Neither approach is usually sufficient on its own in severe infections. Surgical drainage without antibiotics may leave residual infection behind. Likewise, antibiotics alone may struggle to penetrate large abscesses or rapidly reverse mechanical compression. The most effective management strategy combines both disciplines. Through close collaboration between neurosurgeons, infectious disease specialists, pharmacists, and critical care teams, patients receive comprehensive treatment that targets both the infection and its complications. This partnership between surgery and pharmacology remains a cornerstone of modern CNS infection management. Now that we understand the major CNS infections, it's time to explore the antimicrobial arsenal used to treat them. These medications form the foundation of therapy and play a critical role in controlling infection, preventing complications, and improving patient outcomes. Choosing the right antimicrobial is not simply a matter of selecting a powerful drug. Clinicians must carefully consider how the medication works, which organisms it targets, and whether it can reach effective concentrations within the central nervous system. One of the most important groups of antibiotics is the beta-lactam class. These drugs work by interfering with bacterial cell wall synthesis. Without an intact cell wall, bacteria become unstable and eventually die. Among the beta-lactams, cephalosporins are commonly used in CNS infections. Ceftriaxone is a widely prescribed third-generation cephalosporin with strong activity against many gram-positive and gram-negative organisms. Its favorable penetration into inflamed CNS tissues makes it an important component of empirical therapy. Another valuable cephalosporin is cefepime. As a fourth-generation agent, it provides broader gram-negative coverage, including activity against certain more resistant pathogens. This expanded spectrum makes it particularly useful when healthcare-associated infections or resistant organisms are suspected. Another powerful option is meropenem, a member of the carbapenem class. Meropenem has an exceptionally broad spectrum of activity and is effective against many gram-positive bacteria, gram-negative bacteria, and anaerobic organisms. Because of this extensive coverage, it is often reserved for severe or complicated infections where resistance is a concern. When anaerobic bacteria are suspected, metronidazole becomes especially important. This drug belongs to the nitroimidazole class and is highly effective against organisms that thrive in low oxygen environments. Since anaerobes frequently contribute to brain abscesses arising from dental, sinus, or ear infections, metronidazole is often included in treatment regimens. Another key agent is vancomycin, a glycopeptide antibiotic. Vancomycin is particularly valuable when resistant gram-positive organisms are a concern. It is commonly used when there is a risk of methicillin-resistant staphylococcal infections or other difficult-to-treat gram-positive pathogens. Selecting among these agents requires careful clinical judgment. One important consideration is the mechanism of action. Understanding how each drug attacks microorganisms helps clinicians design effective combination therapies. Spectrum of activity is equally important. The chosen regimen must adequately cover the pathogens most likely to be causing the infection. Pharmacokinetic and pharmacodynamic principles also guide decision-making. Clinicians must consider drug absorption, distribution, elimination, and the ability to penetrate CNS tissues. Achieving therapeutic concentrations at the site of infection is essential for successful treatment. The ultimate goal is to match the right drug to the right pathogen at the right dose. By combining knowledge of mechanisms, microbial coverage, and PK/PD principles, clinicians can build effective treatment strategies for even the most challenging CNS infections. Let's take a closer look at one of the most important antimicrobial classes used in CNS infections, the beta-lactam antibiotics. This group includes cephalosporins such as ceftriaxone and cefepime, as well as the carbapenem meropenem. These drugs are classified as bactericidal agents. In simple terms, bactericidal antibiotics do not just slow bacterial growth. They actively kill bacteria. This makes them particularly valuable in severe and life-threatening infections where rapid microbial eradication is essential. To understand how these drugs work, we first need to examine the bacterial cell wall. The cell wall acts like a protective outer shell. It gives bacteria their shape, provides structural support, and protects them from changes in their environment. A major component of this wall is a strong mesh-like material called peptidoglycan. Think of peptidoglycan as the framework that keeps the bacterial cell intact and prevents it from bursting under pressure. Beta-lactam antibiotics target specialized bacterial enzymes known as penicillin-binding proteins, or PBPs. These proteins play a critical role in building and maintaining the bacterial cell wall. Under normal conditions, penicillin-binding proteins help create cross-links between peptidoglycan strands. These cross-links strengthen the cell wall and give it the rigidity needed for survival. When beta-lactam antibiotics are administered, they bind to these penicillin-binding proteins and block their activity. As a result, the bacteria can no longer properly form the cross-links required for a stable cell wall. Without these structural connections, the cell wall becomes progressively weaker. New wall material is produced incorrectly, and existing structures become increasingly fragile. At the same time, bacteria continue to experience osmotic pressure from their internal contents. Normally, the cell wall resists this pressure and maintains cellular integrity. However, once the wall is weakened, it can no longer perform this protective function effectively. Eventually, the bacterial cell begins to swell and lose its structural stability. Water moves into the cell, internal pressure rises, and the weakened wall ruptures. This process is known as osmotic lysis. The bacterial cell essentially bursts, leading to irreversible damage and death. Because beta-lactam antibiotics directly destroy bacterial cells, they are highly effective against many pathogens responsible for brain abscesses, subdural empyema, and spinal epidural abscesses. Their success in treating CNS infections depends not only on their potent mechanism of action, but also on achieving adequate drug concentrations at the site of infection. The key concept is straightforward. Beta-lactam antibiotics kill bacteria by disrupting cell wall construction. By targeting penicillin-binding proteins and preventing peptidoglycan cross-linking, they weaken the bacterial wall, trigger osmotic lysis, and ultimately cause bacterial cell death. Let's now explore metronidazole, one of the most important antimicrobial agents used against anaerobic infections. This drug plays a vital role in the treatment of many brain abscesses because anaerobic bacteria are frequently involved in infections originating from the oral cavity, sinuses, and middle ear. What makes metronidazole particularly interesting is that it functions as a prodrug. A prodrug is a medication that is initially inactive or only minimally active when it enters the body. It must first undergo a chemical transformation before it can exert its antimicrobial effects. This activation process occurs primarily within anaerobic microorganisms. Anaerobic bacteria thrive in environments with little or no oxygen. These unique conditions provide the perfect setting for metronidazole to become activated. Inside anaerobic cells, the drug is reduced by electron transport proteins, including an enzyme system associated with ferredoxin. This reduction reaction converts metronidazole from its inactive form into highly reactive intermediate compounds. Once activated, the drug generates nitro-free radicals. These molecules are extremely unstable and highly reactive. Because of their chemical nature, they rapidly interact with critical cellular components inside the microorganism. The primary target of these reactive radicals is bacterial DNA. DNA contains the genetic instructions required for growth, reproduction, and survival. When free radicals attack DNA, they create structural damage that disrupts normal cellular function. The damage can include strand breaks, alterations in DNA structure, and interference with genetic replication. As these injuries accumulate, the microorganism loses its ability to maintain essential biological processes. At the same time, the free radicals interfere with nucleic acid synthesis. Nucleic acids are necessary for producing new genetic material and supporting cellular replication. Without this capability, the bacteria can no longer multiply effectively. As DNA damage becomes more extensive, the cell's repair mechanisms become overwhelmed. The microorganism eventually loses viability and dies. For this reason, metronidazole is considered highly effective against susceptible anaerobic pathogens. One major advantage of metronidazole is its excellent penetration into many body tissues, including sites of infection within the central nervous system. This characteristic makes it especially useful in treating brain abscesses where anaerobic organisms are suspected contributors. Another important point is its selectivity. Because activation occurs mainly in anaerobic environments, the drug preferentially targets anaerobic microorganisms while limiting activity in oxygen-rich settings. The key concept is simple. Metronidazole enters anaerobic bacteria as an inactive prodrug. It is then activated through reduction reactions involving ferredoxin-related pathways. This process generates powerful nitro-free radicals that attack bacterial DNA and block nucleic acid synthesis. The result is catastrophic genetic damage, loss of cellular function, and ultimately bacterial cell death. This unique mechanism explains why metronidazole remains a cornerstone of therapy for anaerobic CNS infections. Let's now examine vancomycin, one of the most important antibiotics used when resistant gram-positive infections are a concern. In serious CNS infections, vancomycin is often included in empirical therapy to ensure coverage against difficult-to-treat pathogens. Vancomycin belongs to a class of antibiotics known as glycopeptides. Like beta-lactam antibiotics, it is considered bactericidal. This means it actively kills bacteria rather than simply slowing their growth. To understand how vancomycin works, we need to revisit the bacterial cell wall. The cell wall is essential for bacterial survival. It provides strength, maintains shape, and protects the cell from osmotic stress. The main structural component of the bacterial cell wall is peptidoglycan. This complex network forms a rigid framework that keeps the bacterium intact. Building this framework requires a series of carefully coordinated steps. Vancomycin targets a very specific part of this process. It binds tightly to a structure known as the D-ala terminus. This region is located at the end of peptidoglycan precursor molecules that are used to construct the cell wall. Think of these precursors as building blocks waiting to be assembled into a strong protective barrier. By attaching to the D-ala terminus, vancomycin effectively hides these building blocks from the enzymes responsible for cell wall construction. This interference disrupts two critical reactions. The first is transglycosylation, the process that links peptidoglycan units together to form long chains. The second is transpeptidation, the process that creates cross-links between those chains to strengthen the wall. Without transglycosylation, the cell wall cannot properly elongate. Without transpeptidation, the wall cannot develop the strength and stability needed for survival. As a result, the bacterial cell wall becomes weak, incomplete, and structurally unstable. Newly formed bacteria are particularly vulnerable because they depend heavily on continuous cell wall synthesis during growth and division. Meanwhile, the bacterium remains exposed to significant osmotic pressure from its internal environment. Under normal conditions, a healthy cell wall withstands this pressure. However, a defective wall cannot provide adequate protection. Over time, the weakened structure begins to fail. Cracks and defects develop within the cell wall, and the bacterium loses its ability to maintain structural integrity. Eventually, the cell wall ruptures. The bacterial cell can no longer contain its internal contents and undergoes irreversible damage, leading to cell death. One reason vancomycin remains clinically important is its effectiveness against many gram-positive organisms, including strains that may be resistant to other antibiotics. This makes it a valuable option in severe CNS infections where resistant pathogens are suspected. The key concept is straightforward. Vancomycin binds to the D-ala terminus of peptidoglycan precursors, blocks both elongation and cross-linking of the cell wall, weakens bacterial defenses, and ultimately causes cell wall rupture and bacterial death. Understanding how an antibiotic enters the body is just as important as understanding how it kills bacteria. This concept falls under pharmacokinetics, the study of what the body does to a drug after administration. One of the first pharmacokinetic considerations is absorption. Absorption determines how much of a medication reaches the bloodstream and becomes available to fight infection. In serious CNS infections, achieving reliable and therapeutic drug concentrations is absolutely critical. Let's begin with the beta-lactam antibiotics commonly used in focal CNS infections. These include ceftriaxone, cefepime, and meropenem. Although they are highly effective antimicrobial agents, they are not suitable for oral administration when treating severe CNS infections. These medications have poor oral absorption or require drug levels that cannot be reliably achieved through oral dosing. For this reason, they are administered intravenously, or IV. Intravenous delivery places the drug directly into the bloodstream, ensuring rapid and predictable systemic concentrations. This route is particularly important in life-threatening infections such as brain abscesses, subdural empyema, and spinal epidural abscesses. In these situations, clinicians need immediate and dependable antimicrobial exposure. Vancomycin presents a different pharmacokinetic challenge. When taken orally, vancomycin is essentially not absorbed through the gastrointestinal tract. Very little of the drug enters the bloodstream, making oral administration ineffective for systemic infections. Interestingly, this poor absorption can actually be beneficial in certain circumstances. Oral vancomycin is commonly used to treat infections caused by Clostridioides difficile because the drug remains within the intestinal lumen, where the infection is located. However, when treating systemic infections or infections involving the central nervous system, oral vancomycin is not appropriate. To achieve therapeutic concentrations in the bloodstream and infected tissues, vancomycin must be administered intravenously. Now let's consider metronidazole. This drug stands out because of its excellent oral absorption. In fact, metronidazole has an oral bioavailability of nearly 100%. This means that almost the entire administered dose reaches the systemic circulation. As a result, oral and intravenous metronidazole produce very similar drug exposures. Clinically, this offers significant flexibility. Patients who are stable and able to take medications by mouth can often receive oral therapy without sacrificing effectiveness. This characteristic also makes transitions from hospital-based IV treatment to oral therapy much easier. Such transitions can reduce costs, improve patient comfort, and simplify long-term treatment plans. The key takeaway is that route of administration matters. Ceftriaxone, cefepime, meropenem, and vancomycin generally require intravenous administration for CNS infections because reliable systemic drug levels are essential. Metronidazole, on the other hand, achieves nearly identical exposure whether given orally or intravenously. Understanding these pharmacokinetic differences helps clinicians select the most effective route of administration and ensures that antimicrobial therapy reaches its intended target. When treating infections of the central nervous system, getting the drug into the bloodstream is only part of the challenge. The medication must also reach the actual site of infection within the brain, spinal cord, or cerebrospinal fluid. This process is known as drug distribution. One of the biggest obstacles to effective treatment is the blood-brain barrier, often called the BBB. This highly specialized protective barrier regulates what substances can move from the bloodstream into the central nervous system. The blood-brain barrier serves an important protective function. It helps shield the brain from toxins, pathogens, and potentially harmful chemicals. However, this same barrier can also limit the entry of many antimicrobial agents. As a result, not every antibiotic that works well elsewhere in the body will be effective in CNS infections. Drug selection must therefore consider not only antimicrobial activity, but also the ability to penetrate the central nervous system. Let's begin with ceftriaxone and cefepime. These cephalosporins are widely used in the management of serious CNS infections because they can achieve meaningful concentrations within the central nervous system. Under normal conditions, penetration across the blood-brain barrier is somewhat limited. However, when the meninges become inflamed during infection, the barrier becomes more permeable. This increased permeability allows greater amounts of ceftriaxone and cefepime to enter the cerebrospinal fluid and infected tissues. This is one reason why these agents remain important components of empirical treatment regimens for brain abscesses and other severe CNS infections. Meropenem demonstrates even more favorable CNS distribution. This carbapenem is known for its excellent penetration into the central nervous system and its ability to achieve high concentrations within the cerebrospinal fluid. Because of both its broad antimicrobial spectrum and reliable CNS penetration, meropenem is often used when resistant organisms are suspected or when extensive coverage is required. Its pharmacokinetic profile makes it particularly valuable in severe and complicated infections. Now let's consider metronidazole, a drug often described as having exceptional CNS penetration. One of the main reasons for this is its highly lipophilic nature. Being lipophilic means the drug can easily dissolve in and move through biological membranes. This property allows metronidazole to cross the blood-brain barrier with remarkable efficiency. Once in circulation, it distributes extensively into CNS tissues and cerebrospinal fluid. In fact, cerebrospinal fluid concentrations of metronidazole can approach nearly 100% of plasma concentrations. In practical terms, this means the drug reaches the CNS almost as effectively as it remains in the bloodstream. This outstanding penetration makes metronidazole particularly useful for treating anaerobic infections located within the brain and surrounding structures. The key message is simple. Successful treatment of CNS infections depends not only on selecting an antibiotic that can kill the pathogen, but also on choosing one that can cross the blood-brain barrier and reach therapeutic concentrations at the site of infection. Without adequate CNS penetration, even the most potent antimicrobial may fail to achieve its full clinical effect. After a drug has been absorbed and distributed throughout the body, the next important question is simple: how is it removed? This brings us to two key pharmacokinetic concepts: metabolism and excretion. Understanding how a drug is eliminated helps clinicians choose the right dose and avoid toxicity. This becomes especially important in patients with kidney or liver dysfunction. Let's begin with the beta-lactam antibiotics. This group includes agents such as cefepime and meropenem. These drugs are eliminated primarily through the kidneys. After performing their antimicrobial activity, they are filtered from the bloodstream and excreted in the urine. Because the kidneys play such a major role in their clearance, impaired renal function can lead to drug accumulation. If doses are not adjusted appropriately, excessively high drug concentrations may develop. This increases the risk of adverse effects and toxicity. For this reason, renal function is routinely monitored during therapy, particularly in critically ill patients. However, there is an important exception within the beta-lactam family. Ceftriaxone behaves differently from many other agents in its class. Unlike cefepime and meropenem, ceftriaxone undergoes dual elimination. A significant portion is excreted through the biliary system into the gastrointestinal tract, while the remainder is eliminated through the kidneys. Because of this dual pathway, ceftriaxone is less dependent on renal clearance alone. In most patients with renal impairment, dose adjustment is not routinely required. This unique characteristic makes ceftriaxone a particularly convenient option in certain clinical situations. Now let's turn our attention to metronidazole. Unlike many beta-lactams, metronidazole is metabolized extensively by the liver before elimination. The liver uses specialized enzyme systems, including members of the cytochrome P450 family such as CYP2C9 and CYP3A4, to transform the drug into metabolites that can be more easily excreted. Because hepatic metabolism plays such an important role, liver function directly influences how efficiently the drug is cleared from the body. In patients with severe liver disease, metronidazole may accumulate if standard doses are used. To reduce the risk of toxicity, dose reductions or dosing interval adjustments may be necessary. Finally, let's discuss vancomycin. Like many beta-lactam antibiotics, vancomycin relies primarily on renal clearance for elimination. The kidneys remove most of the drug from circulation. As a result, impaired renal function can significantly slow vancomycin elimination and increase the risk of drug accumulation. This is why therapeutic drug monitoring is often performed during vancomycin therapy. Measuring drug concentrations helps clinicians achieve effective treatment while minimizing toxicity. The key message is straightforward. Cefepime, meropenem, and vancomycin depend largely on the kidneys for elimination. Ceftriaxone is unique because it uses both renal and biliary pathways. Metronidazole relies heavily on hepatic metabolism and may require dose adjustments in severe liver disease. Understanding these elimination pathways helps clinicians individualize therapy and optimize patient safety. Understanding how antibiotics kill bacteria is only part of the story. Equally important is understanding how drug concentration influences treatment success. This area of study is known as pharmacodynamics. Pharmacodynamics examines the relationship between drug exposure and antimicrobial effect. Different antibiotics kill bacteria in different ways, and these differences directly influence dosing strategies. Let's begin with beta-lactam antibiotics such as ceftriaxone, cefepime, and meropenem. These drugs exhibit what is known as time-dependent killing. For time-dependent antibiotics, effectiveness depends less on how high the drug concentration rises and more on how long the concentration remains above a critical threshold. This threshold is called the minimum inhibitory concentration, or MIC. The minimum inhibitory concentration is the lowest concentration of an antibiotic capable of preventing visible bacterial growth. For beta-lactams, The key goal is to keep drug concentrations above the minimum inhibitory concentration for as much of the dosing interval as possible. The longer the bacteria are exposed to effective concentrations, the greater the antimicrobial effect. Think of it as applying continuous pressure to the bacteria. Maintaining steady exposure weakens and eventually eliminates the microbial population. Because of this pharmacodynamic property, dosing strategies are designed to maximize the time above minimum inhibitory concentration. Frequent dosing schedules are often used to prevent drug concentrations from falling below effective levels. Another increasingly common strategy involves prolonged or continuous intravenous infusions. Instead of delivering the entire dose rapidly, the medication is infused over several hours or even continuously. Meropenem is a classic example. Extended infusions can help maintain therapeutic concentrations for longer periods, potentially improving bacterial killing and treatment outcomes in severe infections. Now let's look at metronidazole. Unlike beta-lactams, metronidazole demonstrates concentration-dependent killing. For concentration-dependent antibiotics, higher drug concentrations generally produce greater antimicrobial activity. In this case, the intensity of exposure matters more than simply maintaining concentrations above the minimum inhibitory concentration. Two important pharmacodynamic measures help predict effectiveness. One is the peak to MIC ratio, which compares the highest drug concentration achieved to the organism's minimum inhibitory concentration. The second is the AUC to MIC ratio. AUC stands for area under the curve and reflects the total drug exposure over time relative to the pathogen's susceptibility. For metronidazole, larger peak to MIC and AUC to MIC ratios are associated with more effective bacterial killing. Higher exposures can lead to faster and more extensive eradication of susceptible anaerobic organisms. As a result, treatment strategies often aim to achieve robust peak concentrations. Delivering adequate doses helps maximize bacterial damage and promotes rapid microbial death. The key takeaway is simple. Beta-lactam antibiotics rely on time-dependent killing, making sustained concentrations above the minimum inhibitory concentration the primary goal. Metronidazole relies on concentration-dependent killing, where higher peak concentrations and greater overall exposure drive effectiveness. Understanding these pharmacodynamic principles allows clinicians to design dosing regimens that maximize antimicrobial activity and improve patient outcomes. Even when the correct antibiotic has been selected, one important question remains: is the patient receiving the right dose? This is where therapeutic drug monitoring, or TDM, becomes extremely valuable. Therapeutic drug monitoring is the process of measuring drug concentrations in the blood and using those results to guide dosing decisions. The goal is to ensure that drug levels remain high enough to effectively treat infection while avoiding concentrations that may cause toxicity. Think of therapeutic drug monitoring as finding the ideal therapeutic window. Too little drug may allow bacteria to survive and continue causing disease. Too much drug may increase the risk of serious adverse effects. Although many antibiotics are prescribed without routine blood level monitoring, some medications require much closer attention. One of the most important examples is vancomycin. Vancomycin is frequently used to treat severe infections caused by resistant gram-positive organisms, including methicillin-resistant Staphylococcus aureus, commonly known as MRSA. Because treatment success depends on achieving appropriate drug exposure, careful monitoring is often essential. The first goal of vancomycin therapeutic drug monitoring is to ensure therapeutic efficacy. Clinicians want to make sure that drug concentrations are sufficient to kill bacteria and control infection effectively. Modern monitoring focuses on a pharmacodynamic parameter known as the AUC to MIC ratio. AUC, or area under the curve, represents the patient's total drug exposure over time. MIC, or minimum inhibitory concentration, reflects the susceptibility of the pathogen. For serious MRSA infections, treatment guidelines generally aim for an AUC to MIC ratio greater than 400. Achieving this target increases the likelihood of effective bacterial eradication and favorable clinical outcomes. However, effectiveness is only one side of the equation. The second major goal of vancomycin therapeutic drug monitoring is minimizing toxicity. Vancomycin is known to carry a risk of nephrotoxicity, meaning it can cause kidney injury when drug exposure becomes excessive. This risk increases when concentrations remain too high for prolonged periods or when other nephrotoxic medications are used at the same time. Without monitoring, clinicians may unintentionally expose patients to harmful drug levels. This is especially important in critically ill individuals or patients with changing kidney function. By measuring blood concentrations and adjusting doses accordingly, healthcare providers can maintain effective antimicrobial activity while reducing the likelihood of kidney damage. Clinical pharmacists often play a key role in this process. They help interpret drug levels, calculate pharmacokinetic parameters, and recommend individualized dosing adjustments. The key takeaway is simple. Therapeutic drug monitoring helps clinicians tailor treatment to each patient. For vancomycin, therapeutic drug monitoring ensures that drug exposure is high enough to successfully treat MRSA infections while remaining low enough to minimize the risk of severe nephrotoxicity. This careful balance between efficacy and safety is one of the most important principles in modern antimicrobial therapy. Let's now focus on one of the most commonly used antibiotics in the treatment of central nervous system infections, ceftriaxone. This medication has earned a reputation as a dependable and versatile agent in clinical practice. Ceftriaxone belongs to the third generation of cephalosporin antibiotics. As a beta-lactam antibiotic, it works by disrupting bacterial cell wall synthesis, ultimately leading to bacterial death. One reason ceftriaxone is so widely used is its broad spectrum of activity. It provides reliable coverage against many of the pathogens commonly responsible for community-acquired CNS infections. Because of this, ceftriaxone is often considered the workhorse of empirical therapy. When clinicians suspect a brain abscess, meningitis, or another serious CNS infection, ceftriaxone is frequently included as part of the initial treatment regimen. A major target of ceftriaxone is the Streptococcus group of bacteria. This includes several clinically important species that are commonly associated with infections of the brain and surrounding structures. Particularly important is Streptococcus pneumoniae. This organism remains one of the most significant causes of invasive infections involving the central nervous system. Effective early coverage is essential because these infections can progress rapidly and lead to serious complications. Ceftriaxone also provides strong activity against many gram-negative organisms. Among these are members of the Enterobacteriaceae family, a large group of gram-negative rods that can cause severe infections throughout the body. Examples include organisms that may originate from the respiratory tract, gastrointestinal tract, or bloodstream and subsequently spread to the central nervous system. By covering both gram-positive and gram-negative pathogens, ceftriaxone provides a valuable foundation for empirical therapy. Another advantage of ceftriaxone is its favorable pharmacokinetic profile. The drug has a relatively long half-life compared with many other antibiotics. This longer duration of action allows for convenient dosing schedules. In many clinical situations, ceftriaxone can be administered once or twice daily, while still maintaining effective therapeutic concentrations. This simplified dosing offers several benefits. It reduces the frequency of medication administration, improves treatment convenience, and helps streamline patient care in both hospital and outpatient settings. The drug also achieves good penetration into the central nervous system, particularly when meningeal inflammation is present. This characteristic enhances its effectiveness in treating infections located within the brain and cerebrospinal fluid. Of course, no antibiotic should be selected solely based on convenience. Drug choice must always consider the suspected pathogens, local resistance patterns, patient characteristics, and microbiological data when available. The key takeaway is that ceftriaxone remains a cornerstone of therapy for many community-acquired CNS infections. Its broad antimicrobial spectrum, activity against important streptococcal and gram-negative pathogens, reliable CNS penetration, and convenient once or twice daily dosing make it one of the most valuable antibiotics in modern infectious disease management. Let's now explore cefepime, an important antibiotic frequently used in the treatment of serious and high-risk infections. While ceftriaxone is often the workhorse for community-acquired infections, cefepime is commonly chosen when hospital-acquired pathogens are a concern. Cefepime belongs to the fourth generation of cephalosporin antibiotics. Like other beta-lactam agents, it kills bacteria by interfering with cell wall synthesis, causing the bacterial cell to lose its structural integrity and eventually die. What makes cefepime particularly valuable is its expanded antimicrobial spectrum. Compared with earlier generation cephalosporins, it offers broader coverage against many gram-negative organisms. This enhanced activity is especially important in healthcare settings. Patients who acquire infections during hospitalization are often exposed to more resistant bacteria than those seen in community-acquired infections. Hospital-acquired, or nosocomial, infections can develop after surgery, invasive procedures, prolonged hospitalization, intensive care unit admission, or the use of medical devices such as catheters and ventilators. In these situations, clinicians must consider organisms that are not only more aggressive, but also more likely to possess antimicrobial resistance mechanisms. One of the major reasons cefepime is favored in these settings is its strong gram-negative coverage. It remains active against many organisms that may not be adequately covered by narrower spectrum agents. Among these pathogens, one stands out as particularly important: Pseudomonas aeruginosa. Pseudomonas aeruginosa is a highly adaptable gram-negative bacterium known for its ability to survive in hospital environments and develop resistance to multiple antibiotics. It can cause severe infections in vulnerable patients and is associated with significant morbidity and mortality. When a CNS infection is suspected to involve Pseudomonas, clinicians often choose cefepime because of its reliable anti-pseudomonal activity. This makes it a critical component of empirical therapy in selected high-risk patients. Examples may include patients with recent neurosurgical procedures, penetrating head trauma, prolonged hospitalization, or healthcare-associated CNS infections. Another advantage of cefepime is its ability to achieve therapeutic concentrations within the central nervous system, particularly when inflammation increases blood-brain barrier permeability. This allows the drug to reach infected tissues and exert its antimicrobial effects where they are needed most. However, the decision to use cefepime is not based solely on its broad spectrum. Clinicians carefully evaluate patient risk factors, local resistance patterns, culture results, and the likelihood of resistant gram-negative pathogens before selecting therapy. The key takeaway is simple. Cefepime is a fourth-generation cephalosporin that plays a major role in the treatment of nosocomial CNS infections. Its expanded gram-negative coverage and strong activity against Pseudomonas aeruginosa make it an essential option when resistant hospital-associated pathogens are suspected. In severe infections where broad coverage is critical, cefepime often serves as a powerful and reliable therapeutic choice. Let's now discuss meropenem, one of the most powerful antibiotics available for the treatment of serious central nervous system infections. When clinicians face particularly severe or resistant infections, meropenem is often one of the most important treatment options to consider. Meropenem belongs to a class of antibiotics known as carbapenems. These drugs are part of the broader beta-lactam family, but they are distinguished by their exceptionally broad spectrum of antimicrobial activity. Because of their potency, carbapenems are often considered reserve antibiotics. This means they are generally saved for situations where standard therapies may not provide adequate coverage or where resistant organisms are strongly suspected. In clinical practice, meropenem is commonly used for severe, complex, or life-threatening infections. These are situations where treatment failure could result in significant neurological injury, prolonged hospitalization, or increased mortality. One of the most important indications for meropenem is infection caused by multi-drug-resistant pathogens. These bacteria have developed resistance to several commonly used antibiotics, making them much more difficult to treat. As antimicrobial resistance continues to increase worldwide, infections caused by multi-drug-resistant organisms have become a major challenge in modern healthcare. In these cases, meropenem often provides valuable coverage when other agents may no longer be effective. Another key indication involves bacteria that produce extended-spectrum beta-lactamases, commonly known as ESBLs. Extended-spectrum beta-lactamase-producing organisms manufacture enzymes capable of breaking down many beta-lactam antibiotics, including numerous penicillins and cephalosporins. As a result, infections caused by these organisms can be difficult to manage with standard antimicrobial therapy. Meropenem remains highly effective against many extended-spectrum beta-lactamase-producing bacteria because it is resistant to destruction by these enzymes. This characteristic makes it one of the preferred treatment options when extended-spectrum beta-lactamase pathogens are identified or strongly suspected. Meropenem is also particularly valuable in complex polymicrobial infections. These infections involve multiple different microorganisms simultaneously, including combinations of gram-positive bacteria, gram-negative bacteria, and anaerobic organisms. Such mixed infections are not uncommon in brain abscesses that originate from dental infections, sinus infections, or other nearby sources. In these situations, broad-spectrum coverage becomes essential. One major advantage of meropenem is that a single agent can provide activity against a wide range of pathogens. This simplifies treatment and helps ensure that important organisms are not overlooked during the initial stages of therapy. In addition to its broad spectrum, meropenem achieves excellent penetration into the central nervous system. This allows therapeutic concentrations to reach infected brain tissue and cerebrospinal fluid, an essential requirement for successful treatment. The key takeaway is simple. Meropenem is a carbapenem reserved for severe, complicated, or resistant infections. It is particularly valuable for multi-drug resistant organisms, extended-spectrum beta-lactamase producing bacteria, and polymicrobial infections. Its broad antimicrobial coverage and excellent CNS penetration make it one of the most powerful tools in the management of serious CNS infections. Let's now focus on metronidazole, one of the most important antibiotics in the treatment of brain abscesses and other infections involving anaerobic bacteria. Despite being only one component of many treatment regimens, its role is often absolutely essential. Metronidazole belongs to a class of antimicrobial agents known as nitroimidazoles. This group of drugs is highly effective against organisms that thrive in environments with little or no oxygen. These microorganisms are known as anaerobic bacteria. Unlike many other pathogens, anaerobes grow best in oxygen-poor tissues and enclosed spaces where blood supply may be limited. This characteristic makes them common contributors to abscess formation. In fact, anaerobic bacteria are frequently isolated from brain abscesses that originate from dental infections, sinus infections, ear infections, or other infections in nearby structures. Because of this, metronidazole has become an indispensable cornerstone of therapy for anaerobic CNS infections. When clinicians suspect a brain abscess, anaerobic coverage is often considered a critical part of the initial treatment plan. For this reason, metronidazole is commonly included in empirical therapy. Even before laboratory cultures identify the exact pathogen, clinicians frequently add metronidazole to ensure that important anaerobic organisms are not missed. One reason for its effectiveness is its excellent activity against a wide range of clinically significant anaerobic bacteria. Among the most important targets is Bacteroides fragilis. Bacteroides fragilis is one of the most common anaerobic pathogens encountered in serious infections. It has the ability to survive in low oxygen environments and is often associated with abscess formation throughout the body. Another important target is Fusobacterium. These organisms are commonly found in the oral cavity and can contribute to infections that spread from the mouth or throat to deeper tissues, including the central nervous system. Metronidazole is also highly effective against Prevotella species. These anaerobic bacteria are frequently present in oral and dental infections and are often identified as part of mixed bacterial populations within abscesses. An additional advantage of metronidazole is its remarkable ability to penetrate the central nervous system. The drug crosses the blood-brain barrier efficiently and achieves concentrations in cerebrospinal fluid that closely mirror those found in the bloodstream. This excellent tissue penetration allows the drug to reach anaerobic pathogens located deep within brain tissue and abscess cavities. Because brain abscesses are often polymicrobial, treatment usually requires combination therapy. Metronidazole is commonly paired with agents that cover gram-positive and gram-negative bacteria, creating a broad-spectrum regimen capable of targeting the full range of likely pathogens. The key takeaway is simple. Metronidazole is a nitroimidazole antibiotic and a cornerstone of brain abscess therapy. Its potent activity against anaerobic pathogens such as Bacteroides fragilis, Fusobacterium, and Prevotella, combined with outstanding CNS penetration, makes it an essential tool in the management of serious CNS infections. Vancomycin is one of the most important antibiotics used in the management of serious central nervous system infections. When clinicians are concerned about resistant gram-positive bacteria, vancomycin is often one of the first drugs considered. Vancomycin belongs to a class of antibiotics known as glycopeptides. These agents work by disrupting bacterial cell wall formation, leading to bacterial death. Because of its potent activity against many resistant organisms, vancomycin has become a cornerstone of modern antimicrobial therapy. In clinical practice, vancomycin is widely regarded as the gold standard for treating resistant gram-positive infections. Its importance has grown over time as antimicrobial resistance has become an increasingly significant healthcare challenge. One of the most important pathogens targeted by vancomycin is methicillin-resistant Staphylococcus aureus, better known as MRSA. This bacterium is a strain of Staphylococcus aureus that has developed resistance to many commonly used beta-lactam antibiotics. Methicillin-resistant Staphylococcus aureus infections can be particularly difficult to treat because therapeutic options are more limited. These infections can involve the bloodstream, lungs, bones, surgical sites, and in some cases, the central nervous system. When methicillin-resistant Staphylococcus aureus reaches the CNS, the consequences can be severe. Delayed or inadequate treatment may result in significant neurological damage, prolonged hospitalization, or even death. For this reason, clinicians aim to provide effective coverage as early as possible. One of the key principles of CNS infection management is that treatment often begins before the exact causative organism is identified. Waiting for culture results can take valuable time, and serious infections may progress rapidly during that period. As a result, vancomycin is almost universally included in empirical antimicrobial regimens whenever resistant gram-positive pathogens are considered a possibility. Its inclusion provides an important safety net during the early stages of treatment. This approach ensures that methicillin-resistant Staphylococcus aureus is covered from the very beginning, even before microbiological confirmation becomes available. Once culture and susceptibility results are obtained, clinicians can reassess the regimen and determine whether vancomycin is still required. If methicillin-resistant Staphylococcus aureus and other resistant gram-positive organisms are ruled out, therapy may be narrowed to more targeted antibiotics. This practice, known as antimicrobial stewardship, helps reduce unnecessary drug exposure and limits the development of resistance. Another reason vancomycin remains so valuable is its proven clinical track record. Decades of experience have established its effectiveness in treating serious gram-positive infections when used appropriately and monitored carefully. The key takeaway is simple. Vancomycin is a glycopeptide antibiotic and the gold standard for many resistant gram-positive infections. Its most important target is methicillin-resistant Staphylococcus aureus, and because resistant pathogens cannot be excluded early in treatment, vancomycin is routinely included in empirical CNS infection regimens until laboratory results provide a clearer picture of the causative organism. Cephalosporins are among the most commonly used antibiotics in the treatment of serious CNS infections. Drugs such as ceftriaxone and cefepime are highly effective and generally well tolerated. However, like all medications, they are associated with important adverse effects that clinicians must recognize and monitor. Understanding these safety considerations is essential because successful treatment involves more than eliminating the infection. It also requires minimizing drug-related complications and ensuring patient safety throughout therapy. Let's begin with ceftriaxone. This third-generation cephalosporin is widely used because of its broad antimicrobial spectrum, excellent CNS penetration, and convenient dosing schedule. One unique characteristic of ceftriaxone is its elimination pathway. Unlike many other beta-lactam antibiotics that rely mainly on renal excretion, ceftriaxone is eliminated through both the kidneys and the biliary system. Because a substantial portion of the drug is excreted into bile, high concentrations can accumulate within the gallbladder. In some patients, ceftriaxone can combine with calcium and form precipitates within the biliary tract. This phenomenon is known as biliary sludge or pseudolithiasis. The term pseudolithiasis literally means false stones, because these deposits can resemble gallstones on imaging studies. Fortunately, most cases are asymptomatic and discovered incidentally. However, some patients may develop abdominal discomfort, nausea, right upper quadrant pain, or signs of biliary irritation. The good news is that biliary sludge is usually reversible. Once ceftriaxone therapy is discontinued, the precipitates often resolve without the need for surgical intervention. Now let's turn to cefepam. This fourth-generation cephalosporin is highly valued for its expanded gram-negative coverage, particularly against hospital-acquired pathogens and suspected Pseudomonas infections. Although cefepam is an effective antimicrobial agent, its most important safety concern is neurotoxicity. This adverse effect becomes particularly relevant in critically ill patients and those with impaired kidney function. Because cefepam is primarily eliminated through the kidneys, reduced renal clearance can cause the drug to accumulate in the bloodstream. Excessively high concentrations increase the risk of toxic effects on the central nervous system. Neurotoxicity may present in several ways. Patients can develop confusion, agitation, reduced consciousness, difficulty concentrating, or altered mental status. In more severe cases, encephalopathy may occur. Encephalopathy refers to a global disturbance of brain function and can range from mild cognitive impairment to profound neurological dysfunction. Some patients may also experience myoclonus or seizures, particularly when drug accumulation is significant and renal dosing adjustments have not been made appropriately. This is why assessing kidney function is a critical part of cefepam prescribing. Dose adjustments based on renal function help maintain therapeutic efficacy while reducing the risk of neurotoxicity. The key takeaway is simple. Ceftriaxone may cause biliary sludge because of its high biliary excretion, while cefepam carries a risk of neurotoxicity, especially in patients with unadjusted renal impairment. Careful monitoring and appropriate dosing help maximize benefits while minimizing adverse effects. Meropenem and vancomycin are among the most powerful antibiotics used in the treatment of serious CNS infections. While both drugs can be highly effective, they also carry important safety considerations that clinicians must monitor closely throughout therapy. Let's begin with meropenem. This carbapenem antibiotic is often reserved for severe infections, multi-drug resistant organisms, and complex polymicrobial infections. Its broad spectrum and excellent CNS penetration make it a valuable treatment option. However, one important adverse effect associated with meropenem is its ability to lower the seizure threshold. In simple terms, this means the drug can make it easier for seizures to occur in susceptible individuals. The risk is generally low, but it becomes more important in patients who already have neurological disorders, existing seizure disorders, severe CNS infections, or impaired kidney function that allows the drug to accumulate. Fortunately, meropenem is considered one of the safer carbapenems from a neurological perspective. Compared with imipenem, another member of the carbapenem class, meropenem has a significantly lower tendency to provoke seizures. This difference is one reason why meropenem is often preferred when treating infections involving the brain or spinal cord. Nevertheless, clinicians still monitor patients carefully for any signs of neurological changes during treatment. Now let's turn to vancomycin. This glycopeptide antibiotic remains the gold standard for many resistant gram-positive infections, particularly those caused by MRSA. One of the most significant adverse effects associated with vancomycin is nephrotoxicity. Nephrotoxicity refers to drug-induced injury to the kidneys. Vancomycin can directly affect the renal tubules, the microscopic structures responsible for filtering and processing fluid within the kidneys. When excessive drug exposure occurs, these structures may become damaged. The risk increases when high drug concentrations are maintained for prolonged periods. It also becomes much greater when vancomycin is combined with other nephrotoxic medications. Examples include certain aminoglycosides, loop diuretics, and other drugs that can place additional stress on renal function. For this reason, kidney function and vancomycin levels are monitored regularly during therapy. Another well-known reaction associated with vancomycin is red man syndrome. Despite its name, this is not a true allergic reaction. Instead, it is an infusion-related reaction caused by the rapid release of histamine. When vancomycin is administered too quickly, patients may develop flushing, redness of the face, neck, and upper body, along with itching and warmth. Although the appearance can be alarming, the condition is usually manageable and reversible. The most effective intervention is simply slowing the infusion rate. In some cases, antihistamines may also be administered to reduce symptoms and improve patient comfort. The key takeaway is straightforward. Meropenem may lower the seizure threshold, although its risk is lower than that of imipenem. Vancomycin requires careful monitoring because of its potential to cause nephrotoxicity and infusion-related red man syndrome. Recognizing these adverse effects early helps clinicians maximize treatment success while protecting patient safety. Metronidazole is a highly effective antibiotic and a cornerstone of therapy for anaerobic infections, particularly brain abscesses. Its excellent CNS penetration and potent activity against anaerobic bacteria make it an essential part of many treatment regimens. However, like all medications, it can produce adverse effects that clinicians and patients should recognize. Let's start with the more common and generally mild side effects. One of the most frequently reported complaints is a metallic taste in the mouth. Patients often describe this sensation as a persistent bitter or metallic flavor that can affect the taste of food and beverages. Although it can be unpleasant, it is usually harmless and disappears once treatment is completed. Another common but often surprising effect is darkening of the urine. During metabolism, metronidazole produces pigments that may cause the urine to appear darker than usual. This change can range from dark yellow to reddish-brown and may alarm patients who are unaware of the possibility. Fortunately, this effect is typically benign and does not indicate kidney damage or treatment failure. While these mild reactions are usually manageable, longer courses of therapy require closer monitoring because more serious neurological complications can occasionally occur. One important concern is peripheral neuropathy. This adverse effect is most commonly associated with prolonged use or extended treatment durations. Peripheral neuropathy occurs when nerves outside the brain and spinal cord become damaged. Patients may experience numbness, tingling, burning sensations, or a feeling of pins and needles, especially in the hands and feet. Some individuals may also notice reduced sensation or weakness if nerve involvement becomes more significant. Because these symptoms can gradually worsen over time, early recognition is important. Clinicians often monitor patients receiving prolonged metronidazole therapy and reassess treatment if neurological symptoms begin to develop. In many cases, symptoms improve after the medication is discontinued, particularly when identified early. An even rarer but more serious complication is central nervous system toxicity. Although uncommon, this adverse effect can affect structures within the brain and nervous system. Patients may develop dizziness, difficulty with coordination, unsteady gait, confusion, slurred speech, or other neurological abnormalities. In severe cases, symptoms can become significant enough to interfere with normal daily activities. The exact mechanism is not completely understood, but these effects are believed to be related to drug accumulation and direct neurotoxic effects in susceptible individuals. Fortunately, CNS toxicity remains rare and is generally reversible when recognized promptly and managed appropriately. Early discontinuation of the drug often leads to gradual resolution of symptoms. The key takeaway is simple. Metronidazole is generally well tolerated and highly effective against anaerobic infections. Common side effects include a metallic taste and darkened urine, both of which are usually harmless. However, prolonged therapy may increase the risk of peripheral neuropathy, and rare cases of CNS toxicity can occur. Recognizing these adverse effects early helps ensure that patients receive the benefits of treatment while minimizing potential neurological complications. Drug interactions are an important part of antimicrobial therapy. Even when an antibiotic is highly effective against an infection, interactions with other medications or substances can create serious clinical problems. For this reason, clinicians must always look beyond the infection itself and consider the patient's complete medication profile. Understanding key drug interactions helps prevent avoidable complications and improves treatment safety. Let's begin with the interaction between meropenem and valproic acid. Valproic acid is a commonly used medication for seizure disorders and certain neurological conditions. When meropenem is administered to a patient receiving valproic acid, a significant interaction can occur. Meropenem can rapidly reduce circulating valproic acid concentrations, sometimes within just a few days of treatment initiation. Although the exact mechanism is complex, the result is straightforward. Blood levels of valproic acid may fall below the therapeutic range needed to control seizures. This creates a major clinical concern. Patients who were previously stable may suddenly lose seizure protection and become vulnerable to breakthrough seizures. In patients with CNS infections, this is particularly dangerous because neurological complications are already a significant concern. As a result, clinicians often avoid combining these medications whenever possible or implement alternative seizure management strategies. Next, let's discuss the interaction between metronidazole and alcohol. This is one of the most widely recognized antimicrobial interactions. Patients receiving metronidazole are generally advised to avoid alcohol during therapy and for a period after treatment is completed. The reason is the potential for a disulfiram-like reaction. Disulfiram is a medication used to discourage alcohol consumption by producing unpleasant symptoms when alcohol is ingested. A similar reaction may occur when alcohol is consumed during metronidazole therapy. Patients can experience severe nausea, intense vomiting, facial flushing, sweating, headache, and a rapid heart rate known as tachycardia. These symptoms can develop quickly and may be extremely uncomfortable. While the reaction is usually not life-threatening, it can cause significant distress and may require medical attention in severe cases. Finally, let's examine an important interaction involving ceftriaxone and calcium-containing products in neonates. In newborn infants, ceftriaxone can interact with intravenous calcium solutions and form insoluble precipitates within the bloodstream. These calcium ceftriaxone complexes can accumulate within blood vessels and vital organs, creating a potentially catastrophic situation. The resulting intravascular precipitation has been associated with severe complications and can be fatal. Because of this risk, the combination of ceftriaxone and intravenous calcium-containing solutions is contraindicated in neonates. This interaction highlights how drug safety considerations can vary significantly across different patient populations. The key takeaway is simple. Meropenem can dramatically reduce valproic acid levels and increase the risk of breakthrough seizures. Metronidazole combined with alcohol may trigger a disulfiram-like reaction characterized by flushing, vomiting, and tachycardia. In neonates, ceftriaxone must never be combined with intravenous calcium because of the risk of lethal intravascular precipitation. Recognizing these interactions is essential for safe and effective antimicrobial therapy. Let's apply these concepts to a real-world clinical scenario. Imagine a 45-year-old man presenting with a gradually worsening headache. The symptoms have been progressing over the past 2 weeks. He also reports increasing weakness on the right side of his body. At first glance, the presentation may seem somewhat nonspecific. Interestingly, he does not have a fever. This is an important reminder that serious CNS infections do not always present with the classic signs we expect. During the clinical evaluation, another important detail emerges. The patient has severe dental caries and poor oral health. This finding immediately raises concern because infections originating in the teeth and oral cavity can sometimes spread beyond their original location. Bacteria from dental infections may enter surrounding tissues or the bloodstream and eventually seed the brain. When this occurs, a brain abscess can develop over time. As the abscess enlarges, it creates localized inflammation and swelling within the brain. This can increase pressure on nearby structures and produce focal neurological deficits. In this patient, the right-sided weakness provides an important clue. Because the left side of the brain controls movement on the right side of the body, a lesion in the left cerebral hemisphere becomes a strong possibility. Given the combination of progressive headache, focal neurological symptoms, and a potential infectious source, further investigation is essential. Neuroimaging becomes the next critical step. An MRI of the brain is ordered because it provides excellent visualization of soft tissues and is highly sensitive for detecting focal CNS infections. The MRI reveals a ring-enhancing lesion within the left frontal lobe. Ring enhancement is a classic imaging feature often associated with brain abscesses, although other conditions can occasionally produce a similar appearance. To improve diagnostic accuracy, diffusion-weighted imaging, or DWI, is carefully evaluated. This sequence provides information about the movement of water molecules within tissues. The lesion demonstrates restricted diffusion. This finding is particularly important because pus within a brain abscess restricts water movement, producing a characteristic appearance on diffusion-weighted imaging. Restricted diffusion strongly supports the diagnosis of a brain abscess and helps distinguish it from other lesions, such as necrotic brain tumors, which typically demonstrate different diffusion characteristics. At this stage, the diagnosis becomes much more convincing. The patient's dental disease provides a plausible source of infection, the neurological symptoms match the lesion location, and the MRI findings are highly suggestive of a brain abscess. One additional clinical decision is equally important. A lumbar puncture is intentionally withheld. Although lumbar puncture is useful in many neurological conditions, it can be dangerous when a space-occupying lesion is present. A brain abscess may increase intracranial pressure and create pressure differences within the skull. Performing a lumbar puncture under these circumstances could trigger brain herniation, a life-threatening neurological emergency. The key lesson from this case is that brain abscesses may develop gradually and may occur even without fever. MRI with diffusion-weighted imaging is crucial for diagnosis, and lumbar puncture should be avoided when increased intracranial pressure or a mass lesion is suspected. The diagnosis of a brain abscess is only the beginning. Successful treatment requires a combination of surgical intervention and targeted antimicrobial therapy. Neither approach is usually sufficient on its own. Instead, they work together to maximize the chances of recovery. The first priority is source control. In this case, the neurosurgical team performs a stereotactic aspiration of the abscess. Stereotactic aspiration is a minimally invasive procedure that uses advanced imaging guidance to accurately reach the abscess cavity. A needle is carefully inserted into the lesion, allowing pus to be drained. This procedure serves several important purposes. First, it reduces pressure within the abscess and helps relieve compression of surrounding brain tissue. Second, it decreases the bacterial burden, making antimicrobial therapy more effective. Perhaps most importantly, the collected material can be sent to the microbiology laboratory. Cultures help identify the exact organisms responsible for the infection and guide more precise antibiotic selection. While culture results are pending, treatment cannot wait. Empirical antimicrobial therapy is started immediately to cover the most likely pathogens. The first agent selected is ceftriaxone. This third-generation cephalosporin provides excellent coverage against Streptococcus species, which are among the most common organisms associated with brain abscesses originating from dental infections. Because this patient has severe dental caries, oral streptococci are strongly suspected as potential pathogens. Ceftriaxone also offers reliable CNS penetration, making it an excellent choice. The second antibiotic is metronidazole. Dental infections frequently involve anaerobic bacteria that thrive in low oxygen environments. Organisms such as Bacteroides, Fusobacterium, and Prevotella are common components of oral flora and are frequently implicated in brain abscess formation. Metronidazole provides highly effective coverage against these anaerobic pathogens and penetrates brain tissue exceptionally well. The third component of the regimen is vancomycin. Although MRSA has not yet been identified, it remains an important pathogen that cannot initially be excluded. Including vancomycin ensures coverage for resistant gram-positive organisms during the critical early phase of treatment. Once culture results become available, therapy can be refined and narrowed if appropriate. Together, ceftriaxone, metronidazole, and vancomycin provide broad-spectrum coverage against the most likely bacterial causes of a brain abscess while awaiting definitive microbiological data. Treatment of brain abscesses requires patience. Unlike many routine infections, therapy is prolonged because bacteria can persist within the abscess cavity and surrounding tissues. For this reason, intravenous antibiotics are typically continued for 6 to 8 weeks. The exact duration depends on the patient's clinical response, imaging findings, and microbiological results. Because vancomycin can cause nephrotoxicity if levels become excessive, therapeutic drug monitoring is also initiated. Blood concentrations are measured regularly to ensure effective treatment while minimizing the risk of kidney injury. The key lesson from this case is that successful brain abscess management relies on both source control and antimicrobial therapy. Surgical aspiration removes infected material, while ceftriaxone, metronidazole, and vancomycin provide comprehensive antimicrobial coverage during a prolonged treatment course. Let's examine another important clinical scenario that highlights the urgency of focal CNS infections. This case involves a 22-year-old woman who recently recovered from what initially appeared to be a routine sinus infection. At first, her symptoms seemed uncomplicated. However, her condition begins to deteriorate rapidly over a short period of time. She develops a high fever, increasing confusion, and a noticeable decline in mental status. Soon afterward, she experiences new-onset seizures. This combination of fever, altered consciousness, and seizures immediately raises concern for a serious intracranial infection. In patients with recent sinus infections, one dangerous complication is subdural empyema. This condition occurs when pus accumulates between the dura mater and the arachnoid mater, two of the protective layers surrounding the brain. What makes subdural empyema particularly dangerous is the anatomy of the subdural space. Unlike other compartments in the body, this space lacks natural septa or barriers. As a result, once infection enters the subdural space, pus can spread rapidly across large portions of the brain surface. There is very little to slow its progression. This unrestricted spread can trigger widespread inflammation, increased intracranial pressure, cortical irritation, and significant neurological dysfunction. The rapid onset of seizures and declining mental status in this patient reflects the aggressive nature of the disease. Because subdural empyema is a neurosurgical emergency, treatment cannot be delayed. Antibiotics alone are usually insufficient when large amounts of infected material are present. The neurosurgical team therefore performs an emergent craniotomy. During this procedure, a section of the skull is temporarily removed to access the infected area. The accumulated pus is drained, and the subdural space is thoroughly irrigated or washed out. This procedure rapidly reduces the infectious burden, relieves pressure on the brain, and provides material for microbiological analysis. At the same time, broad-spectrum antimicrobial therapy is initiated. Given the severity of the infection and the possibility of multiple pathogens, extensive coverage is required. Meropenem is selected as a key component of therapy. This carbapenem provides exceptionally broad antimicrobial coverage against many gram-positive, gram-negative, and anaerobic organisms. It also achieves excellent penetration across the blood-brain barrier, allowing therapeutic concentrations to reach infected tissues within the central nervous system. Vancomycin is added to ensure coverage against resistant gram-positive pathogens, particularly MRSA, which cannot initially be excluded. An important pharmacological decision is the avoidance of imipenem. Although it is also a carbapenem, imipenem is associated with a greater risk of lowering the seizure threshold. Because this patient has already developed seizures, using a drug with a higher seizure risk could potentially worsen neurological complications. Meropenem provides similar broad-spectrum coverage with a more favorable neurological safety profile. The key lesson from this case is that subdural empyema is a rapidly progressive neurosurgical emergency. Prompt recognition, urgent surgical drainage, and aggressive antimicrobial therapy with agents such as meropenem and vancomycin are essential to prevent permanent neurological injury and improve patient outcomes. Let's examine a third clinical scenario that demonstrates how quickly a spinal epidural abscess can become a neurological emergency. This case involves a 60-year-old man with a history of intravenous drug use, an important risk factor for bloodstream infections and spinal infections. The patient's symptoms begin with severe, localized back pain. At first, the pain may appear to be a musculoskeletal problem. However, over time, the situation becomes much more concerning. The pain is followed by progressive weakness in the legs. Walking becomes difficult, and normal movement starts to deteriorate. Soon afterward, the patient develops urinary retention, meaning he can no longer empty his bladder normally. This progression is a classic warning sign. Severe back pain followed by motor weakness and bladder dysfunction should immediately raise suspicion for spinal cord compression. In a spinal epidural abscess, bacteria invade the epidural space surrounding the spinal cord. As pus accumulates, it creates pressure within the confined spinal canal. The problem is not only the infection itself. The growing abscess mechanically compresses the spinal cord and surrounding nerves. At the same time, it can impair blood flow to neural tissues, causing ischemia and further neurological injury. If treatment is delayed, the damage may become permanent. Paralysis, sensory deficits, and loss of bowel or bladder function can occur. This is why rapid diagnosis is absolutely critical. To confirm the diagnosis, an MRI of the spine is performed. MRI is the imaging modality of choice because it provides excellent visualization of soft tissues, the spinal cord, and epidural structures. The scan reveals an epidural abscess compressing the spinal cord. This finding explains the patient's worsening neurological symptoms and confirms the need for immediate intervention. Because neurological deficits are already present, urgent surgery is required. The neurosurgical team performs a laminectomy. During a laminectomy, a portion of the vertebral bone called the lamina is removed. This creates additional space within the spinal canal and allows direct access to the abscess. The infected material is drained, pressure on the spinal cord is relieved, and specimens are collected for microbiological analysis. This procedure helps prevent further neurological deterioration and improves the chances of recovery. At the same time, broad-spectrum antimicrobial therapy is initiated. Vancomycin is included because there is a high suspicion for methicillin-resistant Staphylococcus aureus, or MRSA. Methicillin-resistant Staphylococcus aureus is a common cause of spinal epidural abscesses, particularly in patients with risk factors such as intravenous drug use. Early coverage is therefore essential. Cefepime is also added to the regimen. This fourth-generation cephalosporin provides excellent gram-negative coverage, including activity against Pseudomonas aeruginosa. Pseudomonas is an important pathogen to consider in high-risk patients and healthcare-associated infections. Cefapime's broad spectrum helps ensure that these organisms are covered while culture results are pending. The key lesson from this case is that spinal epidural abscess is a true medical and surgical emergency. Progressive back pain, leg weakness, and urinary retention should never be ignored. Prompt MRI diagnosis, urgent laminectomy, and early treatment with vancomycin and cefepime are critical for preserving neurological function and preventing permanent disability. As we conclude our discussion of CNS pharmacotherapy, it is important to remember that successful treatment begins with understanding the underlying disease process. In central nervous system infections, pathophysiology is not just an academic concept. It directly guides clinical decision-making. Brain abscesses, subdural empyemas, and spinal epidural abscesses each create unique challenges for antimicrobial therapy. One of the biggest obstacles is drug delivery. In brain abscesses, fibrous capsules may develop around the infection. While these capsules help contain the spread of bacteria, they can also act as barriers that limit antibiotic penetration. At the same time, the blood-brain barrier serves as a highly selective protective shield for the central nervous system. Although it protects the brain from harmful substances, it can also restrict the entry of many antimicrobial agents. This is why drug selection must consider not only the pathogen, but also whether the medication can effectively reach the site of infection. The next key concept is mechanism of action. Understanding how antibiotics kill bacteria helps explain why different drugs are combined during treatment. Beta-lactam antibiotics such as ceftriaxone, cefepime, and meropenem attack the bacterial cell wall. They weaken the structural framework that bacteria need to survive. Vancomycin also targets the cell wall, but through a different mechanism. It interferes with critical steps in peptidoglycan synthesis, ultimately leading to bacterial death. Metronidazole works in an entirely different way. Instead of attacking the cell wall, it enters anaerobic bacteria and generates reactive compounds that damage bacterial DNA. This disrupts genetic function and prevents survival. Pharmacokinetics and pharmacodynamics are equally important. Not all antibiotics penetrate the central nervous system with the same efficiency. Some agents, such as metronidazole and meropenem, achieve excellent CNS concentrations. Others rely on inflammation to improve penetration across the blood-brain barrier. The way antibiotics kill bacteria also influences dosing strategies. Beta-lactams are time-dependent killers, meaning their effectiveness depends on maintaining concentrations above the minimum inhibitory concentration for extended periods. In contrast, metronidazole demonstrates concentration-dependent killing, where higher peak concentrations and greater overall exposure enhance bacterial eradication. Safety remains a critical component of therapy. Many of these medications require close monitoring throughout treatment. Renal function must be assessed when using drugs such as vancomycin, cefepime, and meropenem. Hepatic function becomes particularly important with metronidazole. Clinicians must also remain alert for unique adverse effects, toxicities, and clinically significant drug interactions that could affect treatment outcomes. Perhaps the most important lesson is that CNS infections rarely have a single solution treatment approach. Antibiotics alone are often not enough. Neurosurgeons provide source control through procedures such as aspiration, craniotomy, or laminectomy. Infectious disease specialists guide antimicrobial therapy. Clinical pharmacists optimize dosing, monitor drug levels, and prevent toxicity. The key takeaway is simple. Successful CNS infection management requires an understanding of pathophysiology, precise antimicrobial selection, careful pharmacokinetic and pharmacodynamic planning, vigilant safety monitoring, and effective multidisciplinary collaboration. When surgery and targeted pharmacology work together, survival and recovery become far more achievable goals. Let's test our understanding with a pharmacology question that focuses on antimicrobial mechanisms of action. This is an important concept because knowing how a drug works helps clinicians choose the right therapy for specific pathogens. Here's the question: which antimicrobial agent achieves its bactericidal effect by being reduced by ferredoxin into highly reactive free radicals that damage bacterial DNA? Your options are ceftriaxone, meropenem, vancomycin, and metronidazole. To find the correct answer, let's briefly review each drug. Ceftriaxone is a third-generation cephalosporin. It belongs to the beta-lactam family and kills bacteria by interfering with cell wall synthesis. Its target is the bacterial cell wall, not bacterial DNA. Meropenem is a carbapenem and also a beta-lactam antibiotic. Like ceftriaxone, it disrupts cell wall formation by binding to penicillin-binding proteins. Its mechanism does not involve free radical production or DNA damage. Vancomycin works differently from beta-lactams but still targets the bacterial cell wall. It binds to the D-allo-D-allo portion of peptidoglycan precursors and prevents proper cell wall construction. Again, DNA is not its primary target. Now consider metronidazole. Metronidazole is a nitroimidazole antibiotic and functions as a prodrug. This means it must first be activated before it becomes antimicrobial. Inside anaerobic bacteria, electron transport proteins associated with ferredoxin reduce the drug into its active form. This activation generates highly reactive nitro-free radicals. These free radicals attack bacterial DNA directly. They cause strand breaks, disrupt genetic integrity, and interfere with nucleic acid synthesis. As DNA damage accumulates, the bacterial cell loses its ability to survive and replicate. The result is rapid bacterial death. Therefore, the correct answer is D, metronidazole. The key learning point is simple. Beta-lactams such as ceftriaxone and meropenem, as well as vancomycin, primarily target the bacterial cell wall. Metronidazole is unique because it targets bacterial DNA after activation in anaerobic environments. Whenever you see clues such as ferredoxin, anaerobic activation, nitro-free radicals, or DNA damage, metronidazole should immediately come to mind. This is one of the most distinctive mechanisms of action among the major antibiotics used in CNS infections. Before we move on to the next concept, let's quickly review the answer to our previous question. The correct answer was D, metronidazole. Metronidazole is unique because it acts as a prodrug. Once inside anaerobic bacteria, it is activated through reduction by ferredoxin-associated pathways. This process generates highly reactive free radicals that attack bacterial DNA, leading to cell death. Now let's test our clinical decision-making skills with another important question. Imagine a patient is suspected of having a large brain abscess. Which diagnostic procedure should generally be avoided because it carries a significant risk of brain herniation? Your options are MRI of the brain with diffusion-weighted imaging, CT of the head with contrast, lumbar puncture, or blood cultures. Let's think through each option. MRI with diffusion-weighted imaging is actually one of the most valuable tools for diagnosing a brain abscess. It helps identify abscesses and distinguish them from other brain lesions, such as necrotic tumors. CT scanning with contrast is also commonly used. It can rapidly detect space-occupying lesions, ring-enhancing abnormalities, and associated brain swelling. In many emergency settings, CT serves as an important initial imaging study. Blood cultures are another useful diagnostic test. They can help identify the causative organism and guide antimicrobial therapy. Importantly, obtaining blood cultures does not significantly increase the risk of neurological complications. That leaves lumbar puncture. Under many circumstances, lumbar puncture is a valuable diagnostic procedure. However, the situation changes dramatically when a large brain abscess or other space-occupying intracranial lesion is present. A brain abscess often causes localized swelling and increased intracranial pressure. This creates abnormal pressure gradients within the skull. If cerebrospinal fluid is removed through a lumbar puncture, those pressure differences may suddenly increase. The brain can then shift from its normal position. This movement is known as brain herniation, one of the most feared neurological emergencies. Herniation can compress vital brain structures responsible for breathing, circulation, and consciousness. Without immediate intervention, the condition may rapidly become fatal. For this reason, Clinicians generally avoid lumbar puncture when a brain abscess or other mass lesion with elevated intracranial pressure is suspected. Instead, imaging studies such as MRI or CT are performed first to assess the risk safely. The correct answer is C, lumbar puncture, LP. The key takeaway is simple. MRI and CT help diagnose brain abscesses, and blood cultures help identify pathogens. However, lumbar puncture is generally contraindicated in patients with a suspected large brain abscess because of the potentially catastrophic risk of brain herniation. Before we tackle the next question, let's quickly review the previous answer. The correct answer to question 2 was C, lumbar puncture. In patients with a large brain abscess, lumbar puncture is generally contraindicated because removing cerebrospinal fluid can increase pressure gradients within the skull and potentially trigger brain herniation, a life-threatening neurological emergency. Now let's move on to an important pharmacology question involving drug interactions. Imagine a patient with a brain abscess is receiving meropenem as part of their antimicrobial regimen. During medication review, the clinical pharmacist notices that the patient is also taking a drug for seizure prophylaxis. The pharmacist immediately becomes concerned because meropenem is known to cause a major interaction that can dramatically reduce the effectiveness of one specific anticonvulsant medication. The question is, which medication is most likely affected? Your options are levetiracetam, valproic acid, phenytoin, and gabapentin. Let's analyze each choice. Levetiracetam is commonly used for seizure prevention and generally has a favorable interaction profile. It is not known for a major clinically significant interaction with meropenem. Phenytoin is another well-known anticonvulsant. While it participates in many drug interactions, the classic severe interaction associated with carbapenem antibiotics does not primarily involve phenytoin. Gabapentin is often used for seizures and neuropathic pain. It is eliminated largely through the kidneys and has relatively few major antimicrobial interactions. Now consider valproic acid. Valproic acid is the anticonvulsant most strongly associated with this interaction. When meropenem and other carbapenem antibiotics are administered together, valproic acid concentrations can fall dramatically. The decrease can occur rapidly and may reduce drug levels below the therapeutic range required for seizure prevention. Although the exact mechanism is complex, the clinical consequence is clear. Patients may lose seizure control despite previously stable treatment. This interaction is particularly concerning in patients with CNS infections because neurological complications are already a major concern. A breakthrough seizure can worsen the patient's condition and complicate management. For this reason, clinicians generally avoid combining meropenem with valproic acid whenever possible. If the combination cannot be avoided, alternative anticonvulsant strategies are often considered. This interaction is so clinically significant that pharmacists routinely screen for it whenever a carbapenem is prescribed. The correct answer is B, valproic acid. The key takeaway is simple. Meropenem can cause a profound reduction in valproic acid levels, leading to subtherapeutic concentrations and an increased risk of breakthrough seizures. Recognizing this interaction is essential for maintaining seizure control and ensuring patient safety during treatment of serious CNS infections. Before we move on, let's quickly review the answer to the previous question. The correct answer was B, valproic acid. Meropenem can significantly reduce valproic acid concentrations, sometimes causing levels to fall below the therapeutic range. This interaction can result in loss of seizure control and an increased risk of breakthrough seizures. Now let's test our understanding of diagnostic imaging in brain abscesses. Here's the question. Why is MRI with diffusion-weighted imaging, or DWI, considered the gold standard for imaging a suspected brain abscess? Your options are: it is cheaper than a CT scan, it can differentiate a purulent abscess from a necrotic tumor, it eliminates the need for surgical aspiration, or it identifies the exact bacterial species causing the infection. Let's work through the choices. The first option suggests that MRI is preferred because it is less expensive than CT. In reality, MRI is generally more costly and less readily available in some settings. Cost is not the reason it is considered the gold standard. The third option claims that MRI eliminates the need for surgical aspiration. While MRI provides excellent diagnostic information, it cannot replace aspiration when source control or microbiological diagnosis is required. The fourth option suggests that MRI identifies the exact bacterial species causing the infection. Imaging can reveal the presence and characteristics of a lesion, but it cannot determine the specific organism responsible. That information comes from cultures and laboratory testing. Now let's focus on the second option. One of the greatest strengths of MRI with DWI is its ability to distinguish a brain abscess from other lesions that may appear similar on conventional imaging. Many brain abscesses appear as ring-enhancing lesions. Unfortunately, necrotic brain tumors can also produce ring enhancement, making diagnosis challenging if standard imaging alone is used. This is where diffusion-weighted imaging becomes extremely valuable. DWI measures the movement of water molecules within tissues. In a brain abscess, the cavity is filled with thick pus containing inflammatory cells, bacteria, cellular debris, and proteins. These materials restrict the movement of water molecules. As a result, the abscess demonstrates restricted diffusion on diffusion-weighted imaging sequences. Necrotic tumors generally contain more freely moving fluid and typically do not show the same degree of restricted diffusion. This difference provides a powerful diagnostic clue and significantly improves diagnostic accuracy. Because of its ability to characterize lesions more precisely, MRI with diffusion-weighted imaging plays a central role in the evaluation of suspected brain abscesses. The correct answer is B. It can differentiate a purulent abscess with restricted diffusion from a necrotic tumor. The key takeaway is simple. MRI with diffusion-weighted imaging is considered the gold standard because it provides detailed anatomical information while also helping distinguish pus-filled abscesses from other ring-enhancing brain lesions. This distinction is critical for accurate diagnosis and timely treatment. Before we tackle the next question, let's quickly review the answer to question 4. The correct answer was B. MRI with diffusion-weighted imaging can differentiate a purulent brain abscess from a necrotic tumor. This is possible because pus restricts the movement of water molecules, producing the characteristic finding of restricted diffusion on diffusion-weighted imaging sequences. Now let's move on to a pharmacokinetics and safety question that highlights the importance of dose adjustment in patients with impaired kidney function. Here's the scenario. A patient with a spinal epidural abscess is being treated with high-dose cefepime. During hospitalization, the patient develops acute kidney injury. The clinical team becomes concerned about a serious adverse effect that can occur when cefepime accumulates in the body because of reduced renal clearance. Which adverse effect should they monitor for most closely? Your options are biliary sludge, Redman syndrome, a disulfiram-like reaction, or neurotoxicity. Let's analyze the choices one by one. Biliary sludge, also known as pseudolithiasis, is most commonly associated with ceftriaxone. It occurs because ceftriaxone undergoes significant biliary excretion and can form precipitates within the gallbladder. Red man syndrome is an infusion-related reaction classically associated with vancomycin. It results from histamine release and typically causes flushing, itching, and redness of the upper body. A disulfiram-like reaction is linked to metronidazole when alcohol is consumed during treatment. Symptoms may include severe nausea, vomiting, flushing, and tachycardia. That leaves neurotoxicity. This is the adverse effect most strongly associated with cefepam, especially when dosing is not appropriately adjusted for renal impairment. Cefepam is eliminated primarily through the kidneys. When kidney function declines, the drug may accumulate in the bloodstream and eventually reach excessively high concentrations. As levels rise, the risk of toxic effects on the central nervous system increases significantly. Patients may develop confusion, agitation, altered mental status, difficulty concentrating, or decreased levels of consciousness. In more severe cases, encephalopathy can occur. This refers to widespread dysfunction of brain activity and may present as profound neurological impairment. Some patients may also develop myoclonus or seizures, particularly when drug accumulation is substantial. This risk becomes especially important in patients with acute kidney injury because reduced renal clearance can rapidly increase cefepam exposure if doses are not adjusted appropriately. For this reason, clinicians routinely monitor kidney function and modify cefepam dosing based on renal performance. The correct answer is D. Neurotoxicity, including seizures and encephalopathy. The key takeaway is simple. Cefepam is an effective antibiotic for serious CNS infections, but in patients with renal impairment, drug accumulation can lead to severe neurotoxicity. Careful dose adjustment and close neurological monitoring are essential for safe treatment. As we reach the end of this discussion, one message stands above all others. Central nervous system infections are true medical emergencies. They are dynamic, rapidly evolving conditions that demand timely recognition and decisive intervention. Whether the diagnosis is a brain abscess, subdural empyema, or spinal epidural abscess, delays in treatment can have devastating consequences. Neurological injury can progress quickly, and in severe cases, these infections can become life-threatening. One of the most important lessons is that clinicians cannot rely solely on the classic triad of fever, headache, and focal neurological deficits. While these signs are important, many patients present with only some of these features, or none at all. Instead, healthcare providers must maintain a high index of suspicion. Progressive headaches, altered mental status, seizures, focal weakness, severe back pain, or unexplained neurological decline may all be warning signs of a serious CNS infection. Early recognition is often the first step toward a successful outcome. Once the diagnosis is suspected, rapid source control becomes a priority. Antibiotics are critical, but in many cases they cannot achieve optimal results without surgical intervention. Neurosurgical procedures such as stereotactic aspiration, craniotomy, or laminectomy help remove infected material, reduce pressure on surrounding neural structures, and provide specimens for microbiological analysis. This combination of surgery and antimicrobial therapy gives patients the best opportunity for recovery. Equally important is intelligent drug selection. Choosing the right antibiotic involves much more than identifying a susceptible organism. Clinicians must consider whether the drug can penetrate the blood-brain barrier, achieve therapeutic concentrations within infected tissues, and provide coverage against the most likely pathogens. This is why agents such as ceftriaxone, cefepime, meropenem, metronidazole, and vancomycin play such important roles in CNS infection management. Understanding pharmacokinetics and pharmacodynamics allows clinicians to optimize treatment and maximize bacterial eradication. However, effective treatment does not end with prescribing antibiotics. Continuous monitoring is essential throughout the course of therapy. Therapeutic drug monitoring helps ensure that medications such as vancomycin achieve effective concentrations while minimizing toxicity. Regular assessment of renal and hepatic function helps guide dose adjustments and reduce the risk of adverse effects. Clinicians must also remain vigilant for important drug interactions and medication-related complications that can influence treatment success. Ultimately, successful management of CNS infections is a team effort. Neurosurgeons, infectious disease specialists, pharmacists, radiologists, nurses, and critical care teams all contribute to patient care. Each discipline brings unique expertise, and together they create a comprehensive strategy for diagnosis, treatment, monitoring, and recovery. The final takeaway is simple. Success in CNS infection management depends on prompt recognition, rapid source control, intelligent antimicrobial selection, and rigorous monitoring. When these elements work together, even some of the most challenging neurological infections can be treated effectively, giving patients the best possible chance for survival and recovery. The information presented today was compiled from core pharmacological and clinical guidelines regarding the management of CNS infections. The key reference topics included the distinct pathophysiology of brain, subdural, and epidural abscesses. Pharmacological mechanisms were detailed for cephalosporins, meropenem, metronidazole, and vancomycin, focusing on their specific bactericidal pathways. Pharmacokinetic and pharmacodynamic principles guided our discussion on CNS penetration and dosing strategies. Finally, safety profiles and critical drug-drug interactions were reviewed to ensure clinically safe prescribing practices. Thank you for your attention, and I am happy to take any questions you might have regarding the pharmacology of CNS infections.